Welcome back. I'm Pete Davis, Diabetes and Endocrine Consultant at Sandwell Hospital. This is the second in our series of 5 short lectures about clinical endocrinology. This is going to be the by far and away the meatiest of the lectures, talking about pituitary disease and a little bit about pituitary physiology as well. Here goes. First, a couple of essential facts to remember when you consider the pituitary. You may have heard it described as the conductor of the orchestra, and that's really very true because of where it kind of sits really in terms of endocrine pathways. It sits between the higher controllers like the brain and sort of factors like weight loss and food intake can change endocrine systems regulated through brain mechanisms, and the pituitary kind of passes on some of those signals to the rest of the endocrine systems. It's also, you could say, strategically situated in the sella turcica at the base of the brain. And there are many important structures around. So one of the key things that can happen in pituitary disease is pituitary tumours can cause expansion of the pituitary, and that can lead to a variety of clinical syndromes just because of where the pituitary actually is. It also has, I know it sounds rather like an oxymoron, but it does have interest in embryology, which we'll touch on as we go. Well, let's get that embryology out of the way. There's an anterior pituitary and there's a posterior pituitary. The posterior pituitary, its origin is really more to do with the brain, whereas the anterior pituitary is more to do with the somatic systems of the body. So in the anterior pituitary, these hormones are made. It can be really quite helpful to think about the types of cells that make these hormones, the different types of cells that make these hormones in the anterior pituitary. And you'll be familiar with what each of these hormones does. I won't repeat what's on the slide. The posterior pituitary is quite different. So you've got water regulation through ADH, which we're not going to really say too much about in this series of lectures. And you're probably going to learn more about oxytocin and what it does when you come back to do obstetrics later in your course. So pituitaries, their strategic site. Well, look at this. There's a great big sort of golf ball sized pituitary tumour. It's causing obstructive hydrocephalus that you can see there. This is just what we said about its strategic position. If it enlarges, it can cause bad problems. Problems with cranial nerves, problems in this case pretty extreme with the hydrocephalus. So that's a large pituitary tumour. But bear in mind that actually about 1 in 20 of us has a much smaller abnormality within the pituitary that gets termed a microadenoma. Because these are often picked up when we're performing the scan for some other reason, they're sometimes also called incidentalomas, and we see these in all endocrine tissues. We see it in other endocrine glands that we'll meet throughout this series of lectures too. So tumours of the pituitary are by far and away the most common pathological processes we see from the pituitary gland. And there's a gradation of size from macroadenomas, by definition more than a centimetre in diameter, and with extension sometimes well beyond the pituitary fossa. So they've got to be greater than a centimetre in diameter, and they have to extend to be macro. Mesotumours are up to a centimetre, and they just bulge outside the fossa, and then microadenomas by definition are less than a centimetre and completely contained within the pituitary fossa. So how is pituitary disease going to present? Well, we said about the simple mechanical effect of having a large lesion coming from the sella turcica, and it can present as a space-occupying lesion with typical symptoms of headaches and visual field loss. And I would suggest that you do a little bit of background reading about types of visual field loss It's the sort of thing that your teachers are going to ask you, and it's pretty important clinically as well when you come to assessing patients. But there are two other things the pituitary can do. It can overproduce a variety of hormones. You can consider that as hormonal hypersecretion. Or the tumour itself interferes with normal pituitary processes and leads to hormone deficiency states. So these particular syndromes of hormone excess can be very interesting clinically, and some of the physical signs are incredibly stable, and it means that patients with, for example, acromegaly and perhaps to a lesser extent Cushing's type of problems as well may turn up in your clinical exams. But thinking of the hierarchy of frequency of these, prolactinomas are number one when it comes to their frequency, and then we go down this list as you see then. Growth hormone excess next. Cortisol excess because of an excess of ACTH, and then much rarer hormonal syndromes beyond that. So, commonest first, high blood prolactin levels, hyperprolactinemia, there you go, and prolactinomas. Well, there's something quite important you need to know about prolactin. It's a little bit like, you can think of it rather like vagal tone in the heart. Vagal tone in the heart leads to a lower heart rate. In a similar way, prolactin is actually under tonic inhibition from a substance from the hypothalamus called dopamine. So what's going on under normal circumstances is that dopaminergic tone leads to prolactin levels remaining at what we think of within the normal range. If you lose dopamine inhibition, and this can occur because of various drugs that people might use, prescription drugs, it might occur because of serious car accident causing transection of the pituitary stalk, for example. Deceleration injury can do that. And then what happens is prolactin level just goes up to around about 1,000 under those circumstances when that happens. So prolactin levels of 1,000 we sometimes see when there's a release of this dopaminergic tonic inhibition. So that's the physiological mechanism you need to be aware of. So the commonest sort of tumours of the pituitary are these microprolactinomas. Very, very common. They present quite commonly in women. Why do they present in women more than men? Well, they present because the high blood prolactin interferes with gonadotrophin action, leading to oligoamenorrhea, and it's reckoned to account for about 1 in 4 women that can't conceive this problem. Typically, prolactin would be about 1,000 or thereabouts, and it's treated with drugs that beef up what dopamine can't do, what we call dopamine agonist drugs. And the commonest of these gets called cabergoline. Other earlier drugs were around, but that's the one that we use a lot in clinical practice now. So beyond the microprolactinomas, you might get a large pituitary tumour that makes prolactin, and the brackets on the word prolactin there denote the level of prolactin in the blood, concentration in the blood, and that is proportional to the tumour size. So sometimes we can see prolactin in the hundreds of thousands with a large pituitary tumour. And again, this class of drugs work spectacularly well and can actually shrink these tumours very readily. So second commonest is growth hormone excess, or as it's called, acromegaly. Acro meaning the extremities, megaly being too big. And this slide gives you many of the symptoms and physical signs that people with acromegaly may have. It's important to note that one of the special reasons that we would like to cure acromegaly is that it confers an excess mortality, largely through a whole variety of different cancers. People with acromegaly can be incredibly striking. So here we see a competitor in the, I think it's the World Wrestling Federation, is that right? This character featured in James Bond, in some of the movies when Roger Moore was James Bond. You see these spade-like hands that people have. And here we see a time sequence of a man who developed acromegaly. You can see the enlargement of his nose and his lips particularly well in that series of images. To diagnose acromegaly, you can measure growth hormone, but that is released in pulsatile fashion, so you can be much better off measuring insulin like growth factor 1, which affects the changes within the body of growth hormone. It had an old name called somato of the body, mediate. So that was the old-fashioned name for IGF-1. We said about if there's an excess of a hormone, you do a suppression test. And normally the thing that suppresses growth hormone would be glucose. So glucose should lead to suppressed growth hormone levels if you measure them. But what you see in acromegaly is a paradoxical rise or else no suppression. And that would be how you would biochemically make a diagnosis of acromegaly on your clinical suspicion. As we said, we want to treat it effectively to try and obviate this increase in mortality, and surgery would be our primary mode of treating acromegaly. One of the problems is the tumours that can arise in acromegaly can have sort of like frond-like processes coming out, so sometimes some of that tissue gets left behind, so we often have to depend on additional radiotherapy to the pituitary area, or specific drugs that have been described as endocrine poison, somatostatin analogue drugs that can turn off the production of growth hormone from these abnormal cells. And there is a definition of what a cure would be for safe levels of growth hormone. Here you've got a few images of transsphenoidal surgery, safe approaches on the base of the brain, going through the nose, sometimes going in near the eye as well. Here we see the pituitary gland here being exposed and removed by the surgeon. Now, I'm of an age for this person's name to mean two things. There was very famously Peter Cushing, who was in the Star Wars first movie, but this relates to a famous surgeon, if I can write this well, Harvey Cushing, who would have been operating in New England in 1910, 1915, those sort of times, and he was the father figure for transsphenoidal surgery, and he gives his name to a number of diseases. Well, Cushing's disease is very specific, and it isn't the same as Cushing's syndrome. Cushing's disease is about too much cortisol, or hypercorticolism, which is secondary to disease of the pituitary. So effectively what we're talking about is a pituitary tumour that makes too much ACTH, that in turn affects the adrenals and pushes up the level of cortisol. So excessive ACTH, overproduction of steroid, is what Cushing's disease is all about. This slide shows the many symptoms and physical signs that people with hypercorticolism will have, which you'll see in Cushing's disease. You'll also see it in Cushing's syndrome, which we will meet in the next lecture. The commonest signs and symptoms are shown at the top of the slide there. So people who have too much cortisol, so here I'm using the more generic name, Cushing syndrome, will have these features. So they'll have central adiposity, some wasting of their limbs, and that leads to proximal muscle weakness. And because of loss of collagen, they get thin skin and easy bruising. giving rise to the characteristic so-called abdominal striae, which, because of the absence of collagen, look rather purple in nature rather than the pale normal striae that many people may have. An increase in subcutaneous fat in key areas like the face and over areas of the back give rise to these other physical features as well. And here are some images of people who have Cushing's syndrome, and some of them will have Cushing's disease, no doubt. You see the abdominal striae on this person with central adiposity, and you get the impression of pretty thin limbs in this lady here. And then the other feature we talked about is the intrascapular fat pad that you see on this lady's back. Rather similar to what we talked about in acromegaly, the mainstay of treatment is going to be surgery. And the sort of tumours that people have in Cushing's disease tend to be somewhat smaller and are much more likely to be cured primarily by transsphenoidal surgery. In the past, before those techniques existed, sometimes the treatment was to remove both adrenal glands. So the concept was, if you couldn't get to the base of the brain and the sella turcica, it would be safer to remove both adrenals gland. Well, the younger the patient, the more serious the consequences could be. And there was an entity that got described, which was an aggressive growth of the pituitary and an invasive growth called Nelson syndrome. And what was going on there was that when you remove the adrenal glands, what you don't get is the negative feedback from corticosteroids at the level of the pituitary, so the pituitary can grow in a much less regulated way than it could before, and cause lots of local invasive symptoms. Occasionally, we need to resort to radiotherapy, and if all else fails, there are drugs that can block the adrenal access, and here's one of those mentioned, the tyrapone. Sometimes pituitary tumours are just there and they do nothing else, so-called non-functioning pituitary tumours, and that would be about a third of all pituitary tumours. And here their symptoms are all down to space occupation, pretty typical symptoms that you get with that morning headaches, visual field defects. And then it might give rise to the absence of pituitary hormones, which we will talk about. Again, the mainstay of treatment is going to be surgery. Often you have to resort to using pituitary radiotherapy, and there are no other types of medical therapy that will work for this. So loss of pituitary function, or so-called hypopituitarism, could be congenital, but let's focus on acquired causes, which I would see in adults, my domain. This could be because of pituitary tumours. It could be iatrogenic because of surgery or radiotherapy. One special case of hypopituitarism used to be seen in pregnant women who lost blood at the time of delivery. The pituitary enlarges in size during pregnancy, and the catastrophic drop in blood pressure that could occur from hemorrhage sometimes led to pituitary infarction, and that would present with women being unable to breastfeed and losing weight and having all the features of hypopituitarism that would go along with that. In the past, it used to be uniformly fatal, so it's a dreadful thing, and we've known about this since, I think it was about the late 1940s that Sheehan described this, and gladly this can be dealt with very readily now. Pituitary apoplexy could be thought of as a kind of stroke. It's pituitary infarction occurring often from hemorrhage into the pituitary. You could think of it as a process very similar to subarachnoid hemorrhage in that case. And in fact, SAH, subarachnoid hemorrhage, is very much on its differential diagnosis.